All right, let's dive right into this explainer. Today, we're going to explore exactly how raw, abstract science actually gets transformed into those safe, reliable medications sitting right there in your medicine cabinet.
It's a pretty fascinating question, right? How does a chemical mixed up in a laboratory become a life-saving prescription? Well, answering that requires us to look at an absolutely crucial, yet honestly kind of overlooked field of medical science. It's a hidden process that touches literally all of our lives at some point, but mostly happens entirely behind the scenes.
And that field is clinical pharmacology. It can basically think of it as a vital bridge built with one main three-part goal: promote safety, maximize a drug's effects, and minimize the side effects. It takes all that complex chemistry developed in the lab and figures out exactly how to safely apply it to the wildly unpredictable biology of human beings. So, to help us walk across this bridge today without getting totally lost in the medical jargon, here's our roadmap. We'll cover bridging science and medicine, a history of drug safety, translating research into practice, patient care and monitoring, and finally, big data and drug economics.
Starting off with part 1, bridging science and medicine. Let's look at what exactly a clinical pharmacologist actually does.
Now, what's really interesting here is that these professionals aren't just doctors working alone in a room. We're talking about a massive, multidisciplinary team. The science pulls together experts in medicine, pharmacy, biomedical science, and nursing. And their primary goal? Improving patient care, whether that's directly or indirectly. They do this through a constant cycle of teaching, hands-on research, and everyday healthcare delivery. They're super dedicated to rational prescribing and making sure the next generation of medical professionals knows how to use these medications safely. Moving on to Section 2, a history of drug safety. How did we actually get here? Who were the original architects of this bridge? Well, the journey kicks off way back in 1785. A man named William Withering published some foundational reports on clinical trials and drug toxicity involving foxglove. Now, foxglove might sound like a whimsical garden plant, but it's actually highly toxic. Fast forward a bit to 1884, and John Mitchell Bruce writes his super influential textbook on materia medica. But the modern discipline? That really begins to take shape in the 1940s when Harry Gold officially coins the term clinical pharmacology. And that momentum kept building right up to 1970, when the World Health Organization put together a study group to define the global scope of the whole field. And it's amazing because we still have the tangible artifacts of that history today. Withering's original 1785 text, an account of the foxglove, paved the way for modern, comprehensive textbooks, like Goodman and Gilman's incredibly vital U.S. contribution, The Pharmacological Basis of Therapeutics. These are literally the foundation stones of the drug safety protocols we rely on right now. All right, Section 3, translating research into practice. Let's cross over into the realm of modern research and see exactly how these potential medicines are rigorously tested on human beings. The absolutely crucial thing to understand here is that evaluating a new drug is a highly controlled, step-by-step progression. They scale it up very carefully from a handful of healthy volunteers all the way to thousands of patients just to guarantee safety. Step 1 is Phase 1. This is done with intense scrutiny on just a tiny group of subjects, usually around 24 people. Then comes Step 2, Phase 2, where both the safety and the actual effect of the drug are evaluated in maybe 100 to 200 patients who actually have the disease they're trying to treat. Finally, Step 3 is Phase 3. These are the massive confirmatory trials involving 1,000 to 3,000 patients. This step locks in the safety and efficacy data before a drug ever gets the green light. Now, you might have heard of the randomized controlled trial. Clinical pharmacologists actually pioneered this gold standard method, specifically using placebos as a control to completely remove human bias from medical testing. While it's used across all medical specialties today, the randomized controlled trial is still the absolute rock-solid basis for drug evaluations. It ensures that when a medication claims it's going to work, the data is there to back it up 100%. That brings us to Section 4, patient care and monitoring. Because once a drug passes those trials and hits the pharmacy shelves, the bridge leads straight into ongoing patient care. See, even after a drug is fully approved, specialists rely on some highly precise tactics, like therapeutic drug monitoring. Because, let's face it, human biology is messy and unpredictable. By actually measuring the concentration of a drug floating around in your blood, doctors can get direct guidance for adjusting your specific dose. The whole point here is preventing adverse drug reactions and making sure the treatment doesn't just completely fail. 10,000. That number represents a pretty scary reality. Sometimes, A lethal but extremely rare adverse reaction might only happen in 1 out of every 10,000 patients. Think about that for a second. If a drug is only tested on 3,000 people during phase 3 trials, an adverse reaction that only hits 1 in 10,000 is going to slip right through the cracks. And that is exactly why pharmacovigilance, which is basically spontaneous reporting after a drug hits the market, is an absolute lifesaver. It lets researchers actively mine data to spot those hidden, toxic signals out in the real world.
And finally, Section 5, Big Data and Drug Economics. For this last part, we're going to zoom way out. We're shifting from the microscopic, individual level to the massive, big picture, global scale. Try saying pharmacoepidemiology 3 times fast. So, when randomized trials are practically impossible or straight up unethical, like trying to detect harmful effects on a developing fetus, for example, researchers rely on this massive science. Pharmacoepidemiology links gigantic prescription databases with broader health outcomes to find those toxic signals hiding in the general public. It basically takes clinical pharmacology, mashes it up with epidemiology, and allows decision makers to create safe, smart policies for millions of people at once. But it's not just about safety. Clinical pharmacologists don't just measure if a drug works, they calculate its true real-world value. This is called pharmacoeconomics, and it evaluates a drug across 3 main pillars. You've got clinical outcomes, like safety, economic outcomes, looking at direct costs and lost work productivity, and humanistic outcomes, which are all about patient satisfaction and quality of life. This framework gives us the true value of a treatment, which is absolutely critical for figuring out how to properly spend healthcare resources. Now, here is where things get really exciting. We are rapidly moving away from this old idea of treating the average patient with one-size-fits-all drugs. We are crossing the bridge straight into the era of personalized medicine. By looking at pharmacogenetics, meaning the inherited quirks in your genes that process medications, clinical pharmacologists can actually predict how you specifically will respond to a treatment. Understanding your unique DNA can boost a drug's effectiveness and entirely eliminate those nasty side effects. It is an absolutely incredible glimpse into the future of individualized healthcare. I really hope this explainer has left you super eager to learn more about the brilliant behind-the-scenes science keeping us all safe. So think about this. When you go to pick up your very next prescription, how will your own unique genetic makeup determine exactly what is inside that bottle? It's a pretty fascinating thought to leave you with today.